HER2 positive, non-inferior endpoint, no less than 3% below the standard therapy arm. And you can see kind of how those trials set up. They also had other endpoints that they were measuring, including health economics and so forth. And this is what this looks like. Again, lines that do not separate, even with a piece of paper in between them. The difference between the 12-month and the 6-month arm was about 0.5%. And that met the criteria for being considered non-inferior to go with 6 months. And then when you look at overall survival, again, very difficult to say there's a difference between those two lines as well. So this is another population that may benefit from some sort of de-escalation, right? But when you look at how and what was utilized, it's important to realize who these patients were and what they got, right? So when you looked at chemotherapy type, the majority of the folks got an anthracycline-based regimen. So it's hard to tease apart from this, but 42 and 48% got something with an anthracycline, whether or not they got a taxane. Taxane-based alone, so the option we picked was an unusual one in this trial, 10%. And then some patients got neoadjuvant therapy. Sorry, this is backwards. It's the other way around. Neoadjuvant 15%, adjuvant 85%. And then you can see the timing. So when you looked at the subgroups here, you'll see one group really did not benefit from 6 months of therapy, and that was actually the patients with the taxane base. So this really comes back to Eric Weiner and Sarah Toloni's study, looking at just a simplified regimen of Taxol plus Herceptin for 12 weeks, followed by the Herceptin for a year. That's a group that does not look like we can get by with just 6 months of therapy, right? But otherwise, it looks like for most other folks, that's reasonable. This is hard data, though, to incorporate into practice, right? For our patients with larger cancers, many of us are using pertuzumab in the neoadjuvant setting. And then depending on whether or not there's achievement of a complete pathologic response, we're modifying our therapy after that. For those patients who are unfortunate enough to have to go through a large surgery first and then get the chemotherapy with the anthracycline, I think this data really does apply to them, because this is a group of patients that probably can get by with just 6 months of therapy. But then if you're adding the pertuzumab, what do you do with that? Does that stop at 6 months? Again, a question we don't have an answer to. I put some of those other choices up there because they're interesting. There's actually a study called the Caitlin trial. This is coordinated by, Caitlin. This is coordinated by the Dana-Farber Cancer Center through something called the Translational Breast Cancer Research Consortium. It's a randomized study looking at 1 year of TDM1 versus paclitaxel plus Herceptin. That trial's fully enrolled. We helped enroll to it, and hopefully we'll have data soon. But that's theoretically another de-escalation strategy. I think it'll be appealing for some patients to get a single molecule like TDM1 and not get any chemotherapy. So there's still some things going on in this space, but this is, at least in my mind, a nice thing that we can do for patients is to get them off 6 months. And the other reason why we want to do that is toxicity. I know we all think about Herceptin as something that's just easy to be on, but the truth is there are still women who are put at risk with this molecule. So you can see 4 months of cardiac toxicity being the 4% is the rate of stoppage for the 6-month group versus 8% because of cardiac toxicity. And then, and there was higher toxicities for grade 3 toxicities in general in the 12-month arm. So another reason why this is something we should look to be doing for our patients. Okay, another different kind of patients, triple-negative breast cancer. And this is a complicated story. So this is a 44-year-old woman, status post allo transplant 20 years ago for ALL, with now large node-positive disease. She got dose-dense and then she developed large node-positive disease 10 years ago, and she was treated with dose-dense AC and weekly T, and followed by tamoxifen. And now she has a primary left breast cancer, triple negative. She's status post neoadjuvant paclitaxel times 12, and went to surgery. And you might say, why didn't she get an anthracycline? Well, she had a year of anthracycline back here, and then on top of that got more. So she's well past her lifetime limit of anthracycline, and we didn't want to put her at risk for toxicity from that. So she only got the Taxol, and she had an RCV2, residual cancer burden score of 2. That means there was still a lot of disease left in her breast. Based on that, she got adjuvant capecitabine for 6 months, and now she presented literally 2 weekends ago to an ER with CNS symptoms, and she had 12 brain lesions. She's status post SRS last week. We figured out that she was BRCA1 mutated germline. So what do? And while you're thinking about this question, I'm going to tell you a story about how we figured out she was BRCA1 positive. What do you normally send off? And you guys can just verbalize your answer. What do you normally send off if you're trying to figure out germline testing? Blood. Yeah, but if you send blood from a patient with an allo transplant, what are you sending, right? You're sending the allo transplant donor's cells, right? And so that's not going to give you an answer. So when we first tried to propose for this lady that she get tested, we got repeatedly rejected by insurance companies, but also by companies like Myriad, because they said, we can't give you the answer. So what we actually did for her, and I'm just throwing this out there, if you ever run into this scenario, is we tested her tumor. We used deep sequencing of the Oncoplex panel, so this is about 400 genes that we look at, and they confirmed that the mutation was present in the normal tissue in the biopsy. They figured out the ratios that were there and confirmed there was loss of heterozygosity for BRCA1 in the actual tumor cells, and that's how we got her diagnosis of she's got germline mutated BRCA, BRCA breast cancer. So offer clinical trial with cisplatin ABT88. Some of you would give her elaborate. So again, all of these are reasonable answers, and I put the first one up there just as a tease. So did anybody see this press release recently? Okay. Well, I think we're going to all hear about it in a couple of months when this data is actually presented at a meeting. But the Impassion 130 trial was presented as a press release, I think mostly for financial disclosure reasons. But this is a randomized controlled trial of nab-paclitaxel plus minus atezolizumab. And apparently it was a positive study, positive enough that the company felt they needed to make a press release. So there's a chance in the very near future that this is now a standard of care option for patients in this setting. The combination of a checkpoint inhibitor plus a chemotherapy drug. I think this will be a big win for our patients, and I'm excited to see this data when it does come out. But really, this is a story about potentially PARP inhibitors. She has a BRCA1 mutation. So I'll show on the next slide what PARP inhibitors can do, but in general, we talk about this concept of synthetic lethality when we talk about PARP inhibitors. So this is this idea that if you have a handful of canonical DNA repair pathways available to you in any cell, and you disable one of those, i.e. homologous recombination, eventually these cell lineages will get enough mutations in them that they become a cancer. But even those cancers have to achieve a modicum of DNA repair to be sustainable to survive. And what the PARP inhibitors are essentially thought to do is to kill off another DNA repair pathway. And when you lose two repair pathways, well, it's kind of like sitting on a two-legged stool. It's hard to do. You can't do it. You fall over. These cells accumulate catastrophic amounts of DNA injury that they cannot repair, and then they die. They commit apoptosis. So that's how the PARP inhibitors work. And in theory, they should work for anybody with a germline mutation in BRCA1, 2, but also other homologous recombination genes like PALB2 and others. The first of these drugs was approved just a few months ago now by the FDA for BRCA1 and 2 mutated metastatic breast cancer. That's based on the Olympia trial. There are other trials going on, the Rio trial, the Bravo trial, and the company-sponsored trial of Libra. And some of you might remember the Umbraco trial that was presented at San Antonio this past year with very similar data to the elaborate study. So here's what the elaborate data looks like from Ross and Nadal's New England Journal of Medicine publication. So pretty meaningful progression-free survival difference. And I know it's hard to see here, but that's roughly 5-ish months versus 9-ish months. And then this is the overall survival. So that was not identified in the study, but some would argue this is too small a study to show that. We'll see if larger trials are ever done to show that there can be an overall survival benefit with single-agent olaparib or similar drugs. This is the Umbraco trial from Jennifer Litton, presented at San Antonio. It's still not published to my knowledge, looking at tallow versus physician's choice. And here you'll see very similar numbers, 8.6 versus 5.6 months. The response rates are quite different, and they evoke what was seen in the Olympia trial. And then overall survival benefit, again, not reached in this study. So another choice available to us, and this is being registered and hopefully will be approved by the FDA as well, so we'll have a couple molecules. Some of you might say, are these just me-too molecules? It turns out the PARP inhibitors, each one of them works quite differently from each other, and they may have different toxicity profiles as a result of that as well. So for me, it'll be interesting to see if we'll have a hands on multiple ones of these agents and whether or not we can figure out if there's unique uses for some in some circumstances versus others. This is is actually a study that was presented at ASCO this year as well by one of our newest colleagues, Dr. Vinayak. And this is looking at a PARP inhibitor, niraparib, plus a checkpoint inhibitor, pembrolizumab. This meets the criterion of the Eli Esty. Do any of you know Eli Esty? He's a famous AML researcher where I work. Yeah, he's got this great quote that he uses all the time: "No two drugs too dumb to try." This might fit that category. No, there's actually good rationale for this. So here's the rationale. So if you take a cell and drop a PARP inhibitor on it, keep in mind that's a DNA damage response pathway, right? So this cell now starts accumulating mutations potentially, and then you get funny-looking DNA sequences that make funny proteins, and the funny proteins should excite the immune system. And if you've got this going on, there's actually a set of sensors, there are pattern recognition receptors and the like, that say there's something in this cell that shouldn't be there, and they respond by upregulating certain immune phenomena. And so one of the pathways that seems to be turned on by dropping a PARP inhibitor on a cell is something called the C-gas sting pathway. And these are intracellular sensors for abnormal DNA sequences. And once that happens, they're supposed to stimulate the immune response by turning on interferon response elements. And then you're supposed to get this immune response. So the idea then is to do both, to unhinge the immune blockade that's going on with the checkpoint inhibitors, and then combine it with a PARP inhibitor. So this is a trial that was essentially a phase 2 study, small trial. And when you look at the response rates, they differed by whether or not there was a germline